Hi guys, welcome to the lecture series, and today we're going to be talking about appendicitis. How is it diagnosed? What are the methods of surgical removal? We'll also look at complicated cases and how to manage. So appendicitis just simply means an inflammation of the appendix. So, what is the appendix? The appendix is a tubular structure, as seen here, closely attached to the cecum, the base of the cecum. So, pathophysiology, how does the appendix get inflamed? Well, what happens is um, everything revolves around intraluminal obstruction. Intraluminal obstruction would mean obstruction of the lumen of the appendix, and this could happen from foreign bodies blocking the lumen of the appendix, as seen here. It could also be due to fecolates obstructing the lumen. So, what happens when there's a luminal obstruction? Because the part of the appendix distal to the obstruction will still secrete intestinal juices, there will be a raised intraluminal pressure, which puts pressure on the walls of the appendix. This increased intraluminal pressure would cause an ischemic injury to the walls of the appendix. And of course, the ischemia could lead to rupture and spillage of fecal contents into the peritoneal cavity. So, by virtue of presentation, how does appendicitis present? Well, it could present in acute or chronic forms and other forms in between. So, when we talk of the acute presentation, we're talking about a rapid onset or rapid progression of symptoms, usually within 6 to 48 hours. Patients present with very severe right iliac fossa pain, tenderness, fever, usually occasional vomiting, but the the main thing is the presentation is very rapid, meaning a patient that was otherwise well would rapidly present with a severe right iliac fossa pain. While for the subacute, symptoms develop much slower, usually ranging from days to weeks. Unlike the chronic presentation, where it's typically a longer duration, symptoms can last months to years with acute exacerbations in between. So let's move on to clinical features. Clinical features, by this we mean the signs and symptoms of a patient with appendicitis. So the most important symptom, of course, is pain. severe right iliac fossa pain, which of course you can elicit tenderness when you examine. Also, rebound tenderness can be noted. Then, one classical feature of the pain is pain may initially be periumbilical because of the shared innervation or the dermatomal innervation between the appendix and the T10 dermatomal level, though the periumbilical pain is not usually seen in all patients. Then there are other signs that could be elicited, ranging from SWAS, Rovsing, obturator sign, as well as the pointing sign. But however, it should be noted that absence of these signs do not usually rule out appendicitis. So the most important feature is right iliac fossa pain and tenderness. Moving on, this is an image showing how to elicit the Rovsing sign. The patient feels pain in the right iliac fossa, but when the left iliac fossa is palpated, patient feels pain in the right iliac fossa because of the irritation of the parietal peritoneum. Also, the SWAS sign, though not shown here, extension of the hip will result in right iliac fossa pain. The obturator sign, internal rotation of the hip, will result in right iliac fossa pain. Pointing sign just means the patient points to the site of maximum pain, which is the right iliac fossa. Then another important sign that is usually seen, especially in children, is a constant hip flexion where the child assumes a posture of constant hip flexion, right hip flexion. Any attempt to extend the hip is resisted, and this because irritation of the psoas muscle by hip extension will also cause pain. So, moving on, we go to investigation. The main investigation in appendicitis is radiological, though blood investigations are also done, like the complete blood count, which may show neutrophilia, but this is not specific to appendicitis, as neutrophilia can be seen in other conditions. So the major investigations done are ultrasound, CT scan or contrast CT, MRI, also diagnostic laparoscopy. So the major finding is an increased or an enlargement in the size of the lumen of the appendix, usually greater than 6 millimeters. So this first image is an ultrasound scan image showing increased luminal diameter, while the other image is an MRI image also showing increased luminal diameter of the appendix. Well, apart from making diagnosis, radiological investigations are also very important to exclude other differentials that could mimic the presentation of acute appendicitis. These differentials, the most important, especially in females, would be ectopic pregnancy and ovarian cysts and their complications. Ectopic pregnancy can be ruled out with a pregnancy test, and ovarian cysts will be shown on ultrasound or other imaging. Other important differentials include inflammatory bowel disease, Crohn's disease, and ulcerative colitis, as well as urinary tract infections or stones along the urinary tract that could also present with pain in the right iliac fossa. So the approach to surgery could either be open appendectomy, as seen in this first image, or laparoscopic appendectomy, depending on the skill set of the operating surgeon as well as the availability of laparoscopic instruments. So, talking about the open appendectomy, the landmarks for making the entry incision are shown here. This is the umbilicus, the anterior superior iliac spine. Then this is the phalansteal line. So the incision is made at the junction between the medial two thirds and the lateral one third of this imaginary line. For younger individuals with scaphoid abdomens, the incision is best made at the lateral edge of the phalansteal line. This is a more cosmetically appealing incision as the incision is hidden. Alternatively, the typical lens incision can be made, especially in larger adults with distended or fatty abdomens. So, what is the intervention done at surgery? First is to gain entry into the peritoneum. Of course, gaining entry will cut across layers such as the skin, subcutaneous layer, the external oblique and internal oblique aponeurosis, the transversalis fascia, the parietal peritoneum, and finally into the peritoneal cavity. All these steps are shown in other videos on the channel, but eventually the main intervention at surgery is to ligate and divide the mesoappendix, ligate and divide the appendix. Other things could be done depending on the nature of the case, if straightforward or complicated. Other things like deciding to leave a drain, having to drain feculent matter or discharge for a ruptured appendix, normal saline lavage, decision to do a right hemicolectomy, and sometimes there's also the decision to close up and do nothing. Though the details of all this will be explained in subsequent lectures. Complications seen at surgery. I think the most common problem encountered at surgery is difficulty finding the appendix in some instances, usually due to adhesions, inflammatory adhesions, tearing down the appendix and cecum. Another complication seen is the appendix mass. With proper clinical examination, especially for non-obese individuals, appendix mass can be palpated even before surgery. But for obese individuals with fatty abdomen, appendix mass may be encountered in surgery. This is one of the cases where you close up and do nothing, which we talked about on the previous slide. Appendix mass is essentially an inflammatory mass consisting of the cecum, the greater, a portion of the greater omentum wrapped around the cecum. Is the body's way of walling off the spread of the inflammation. Then other findings, though not common, are cecal tumors. With proper radiological investigations, this could be identified pre-op. Then also a common finding is ruptured appendix, though with variations in the amount of spillage of fecal contents that is seen. Spillage, of course, could lead to intra-abdominal abscesses. A not so common finding is gangrenous appendix and gangrenous cecum. Other complications include intra-op bowel injury. This usually occurs when entry into the peritoneal cavity is too rapid and the surgeon is not careful enough to avoid sharp dissection. Another complication is slipped sutures. The sutures used to tie the mesoappendix or the appendix could slip, resulting in hematoma formation or spillage of fecal matter. Then, of course, complications of anesthesia, which is a general anesthesia that's commonly used. There could be complications arising from general anesthesia. So, in summary, we've talked about how to diagnose appendicitis as well as surgical approach to appendectomy and complications that can be seen.